Okay, friends, today we're talking about respiratory assessment. And I need to be honest with you. When I first started learning this chapter, I thought respiratory assessment was just a collection of random noises and made up words. Crackles, wheezes, rhonchi, bronchophony, egophony, whispered pector eloqui, fremitus. At some point, I genuinely thought nursing instructors were making things up just to see if we'd write them down. And somehow we were supposed to memorize all of it. But here's what finally made it click for me. Respiratory assessment is not about memorizing 50 random findings. It's about answering 3 questions. Can the patient move air? Can the patient exchange gases? And how hard are they working to do it? If you can answer those 3 questions, almost everything in this chapter starts making sense. And by the end of this video, you're going to understand respiratory assessment instead of just memorizing it. Let's do it. Before we touch a stethoscope, let's talk about what the lungs are actually trying to do. The respiratory system has 2 jobs: bring oxygen in, get carbon dioxide out. That's it. Every breath your patient takes is trying to accomplish those 2 things. At the center of all of this are the alveoli, tiny little air sacs. Think of them as exchange stations. Oxygen enters the blood. Carbon dioxide leaves the blood. Life is good. When those alveoli fill with fluid, collapse, become inflamed, or get blocked, that's when we start hearing abnormal findings. And that's why throughout this video, I'm going to keep asking the same question. What is happening to the air? Because if you understand what's happening to the air, most respiratory questions become easier. Okay, friends, let's see if this is making sense. NCLEX question. A patient has adequate blood flow to the lungs, but the alveoli are filled with fluid. What problem is most likely to occur? A. Increased cardiac output. B. Impaired gas exchange. C. Increased blood pressure. D. Increased oxygen delivery. Pause here if you want to answer. The answer is B. Impaired gas exchange. Because oxygen cannot move efficiently across fluid-filled alveoli. And that single concept explains a huge portion of respiratory assessment. Let's keep anatomy practical. Right lung, 3 lobes. Upper, middle, lower. Left lung, 2 lobes. Upper, lower. Why? Because the heart is selfish. The heart takes up space on the left side, so the left lung loses a lobe. Heart stole the 3rd bedroom. That's literally how I remember it. Now here's an exam tip. Most of what you're listening to on the back is lower lobes. Most of what you're listening to on the front is upper lobes. And that becomes important when you're trying to figure out where abnormal sounds are coming from. Listen, everybody wants to jump straight to the stethoscope. Nobody wants to ask questions. But NCLEX absolutely loves subjective assessment. Imagine your patient says, "I'm short of breath." Okay, that tells us almost nothing. When did it start? What makes it worse? What makes it better? Do you cough? Do you wheeze? Do you have chest pain? Does it wake you up at night? Do you smoke? Have you ever been diagnosed with asthma? The answers to those questions can completely change your clinical thinking. Now let's talk sputum, because NCLEX loves sputum. Clear or white sputum? Often viral. Yellow or green? Think infection. Rust-colored sputum? Tuberculosis should pop into your head. Pink frothy sputum? That should immediately make you think pulmonary edema. And that is one of those clues that practically gives away the answer. Okay, friends, now we're finally getting to the point where we can actually look at the patient. And here's the thing. Inspection is free. No stethoscope. No equipment, no fancy skills, just your eyes. And honestly, some of the most important respiratory findings can be spotted before you ever touch the patient. When I walk into a room, I'm immediately looking at how fast are they breathing? How hard are they breathing? Do they look comfortable? Or do they look like they're fighting for every breath? Because those are 2 very different situations. One of the biggest things we're looking for is increased work of breathing. And this is where nursing school starts giving us clues. Accessory muscle use, nasal flaring, retractions, tripod positioning. All of these findings tell us the same thing. Breathing has become work, and breathing should not be work. Let's talk about tripod positioning, because NCLEX absolutely loves tripod positioning. If a patient is leaning forward, hands on their knees, trying to catch their breath, they're not getting comfortable. They're trying to breathe. Tripod positioning helps open the diaphragm and allows the lungs to expand more effectively. When I see tripod positioning, my brain immediately goes, something respiratory is happening. Now add accessory muscle use. You start seeing muscles in the neck helping with breathing. You see shoulders lifting. You see effort. That's a red flag because breathing should happen automatically. The second the body starts recruiting extra muscles, it means we're struggling. Okay, friends, quick question. A nurse enters a patient's room and notices the patient sitting forward with hands on their knees while breathing rapidly. Which assessment finding is most concerning? A. Symmetrical chest expansion. B. Respiratory rate of 18. C. Tripod positioning. D. Vesicular breath sounds. Pause here. The answer is C. Tripod positioning, because it indicates increased work of breathing and possible respiratory distress. And honestly, if I see tripod positioning, I'm paying attention before I ever grab my stethoscope. Now let's talk respiratory rates, because students get these mixed up all the time. Tachypnea, bradypnea, hyperventilation, apnea. And they all sound similar enough to make your brain angry. So here's how I remember them. Tachypnea, fast, shallow. Think tiny, quick breaths. Hyperventilation, fast, deep. The word hyper makes me think extra. Extra breathing, extra depth. Bradypnea, slow breathing. Apnea, no breathing. And that's generally a bad life choice. This is one of those areas where NCLEX likes to test whether you understand the difference. Because fast does not always mean deep, and deep does not always mean fast. Make sure you're separating those concepts. Now let's look at the shape of the chest, because sometimes the body gives us clues before we ever listen to lung sounds. Normally, the chest is wider side to side than it is front to back. We call this the AP diameter, anterior to posterior diameter. Normally, it's about 1 to 2. Now enter COPD. Years of air trapping can cause something called barrel chest. Instead of a normal ratio, the chest starts looking closer to 1 to 1. Think of an overinflated balloon. Air gets trapped. The lungs stay expanded. The chest changes shape. And suddenly we have one of the classic findings associated with chronic lung disease. You might also hear about kyphosis and scoliosis. And here's why they matter. Anything that changes the shape of the chest can potentially affect breathing. Now let's talk about something students sometimes overlook. Not everybody breathes the same. Kids are different. Pregnant patients are different. Older adults are different. Let's start with infants. Babies breathe faster than adults. That's normal. Secondhand smoke increases the risk of asthma, respiratory infections, ear infections, and even sudden infant death syndrome. Now let's talk about older adults. As we age, the lungs lose elasticity. Gas exchange becomes less efficient. A nurse is assessing an older adult patient. Which age-related change should the nurse expect? A. Increased lung elasticity. B. Increased chest wall expansion. C. Decreased respiratory reserve. D. Larger alveolar surface area. Pause here. The answer is C. Decreased respiratory reserve. Older adults have less ability to compensate when respiratory problems occur. And that's why respiratory assessment becomes even more important in this population. Okay, friends, welcome back. This is where nursing school starts throwing around words that sound completely made up. And one of my favorites is fremitus, pronunciation, fremitus. At some point, I thought they were making this word up. But before we get to that, let's talk about chest expansion. When we assess chest expansion, we're looking for symmetry. Both sides of the chest should move equally. Think about what happens if one lung isn't expanding properly. Maybe there's pneumonia. Maybe there's atelectasis. Maybe there's a pneumothorax. Suddenly, one side of the chest doesn't move as much. And that's a clue. Remember, assessment is clue collecting. We're gathering evidence about what's happening inside the body. When I think about chest expansion, I ask myself, are both lungs participating? Because if one side is lagging behind, something deserves a closer look. That's it for chest expansion. In part 2, we're diving deep into tactile fremitus and that cheat code I mentioned earlier. I'll see you there. Now let's get back to fremitus. The patient says 99, and you're feeling how those vibrations travel through the chest wall. Now here's the biggest cheat code from this section. Fluid carries vibration better than air. Let me say that again. Fluid carries vibration better than air, because this single concept explains almost everything. Imagine 2 lungs. One is full of normal air. One is filled with consolidation from pneumonia. Which one carries vibration better? The one with consolidation, the one with fluid. And that means increased fremitus. More vibration, not less, more. Because fluid conducts vibration better than air. Now let's flip it. Imagine a pneumothorax. Air collects in the pleural space. Or imagine a pleural effusion. Fluid collects outside the lung. Now those vibrations have trouble reaching your hand. The result is decreased fremitus. And this is why I don't memorize random findings anymore. I ask one question: what is happening to the vibration? Once you answer that, the assessment finding usually makes sense. Okay, friends, let's see if this is making sense. A patient has right lower lobe pneumonia with consolidation. What would the nurse expect to find during tactile fremitus assessment? Pause here and think about your answer. I'll give you a few seconds. The answer is increased fremitus, because fluid carries vibration better than air. That's the cheat code. And honestly, if you remember that one rule, you'll answer a lot of respiratory questions correctly. Let's lock this in. Chest expansion should be symmetrical. Fremitus is vibration. Fluid carries vibration better than air. Consolidation causes increased fremitus. Pneumothorax and pleural effusion usually decrease fremitus. And remember, you don't have to memorize everything. If you understand what's happening to the air and what's happening to the vibration, most of these findings start making sense. In the next section, we're tackling percussion. And that's where we'll start figuring out how to tell whether the lung contains normal air, too much air, or fluid. Okay, friends, welcome back. We're moving into percussion. And honestly, this is one of those skills that most nursing students forget exists until about 3 hours before the exam. But percussion is actually pretty simple. We're basically asking one question: how much air is in there? That's it. How much air is inside the lung? Normal lungs contain air. When we percuss over healthy lung tissue, we hear resonance. Think hollow. Think drum. Think normal air-filled lungs. Normal amount of air. Normal sound. Now let's imagine fluid moves in. Maybe pneumonia. Maybe pleural effusion. Maybe pulmonary edema. The fluid replaces the air, and the sound changes. Instead of resonance, we hear dullness, because fluid doesn't vibrate the same way air does. Now let's go the opposite direction. Too much air, maybe emphysema, maybe a pneumothorax. Now we hear hyperresonance. More air than normal, louder than normal, more hollow than normal. Here's how I remember it. Normal air equals resonance. Fluid equals dullness. Too much air equals hyperresonance. That's basically the entire percussion chapter. Okay, friends, let's see if this is making sense. A nurse percusses over a patient's lung and hears a dull sound. Pause here and think about what that finding suggests. I'll give you a few seconds. Ready? Dullness suggests fluid or consolidation because something replaced the normal air in the lung, and that changes the sound. Okay, now we're finally at the section everybody thinks about when they hear respiratory assessment, the breath sounds. And honestly, this is where most students start trying to memorize things. I don't. I try to understand what's causing the sound. Because once you understand the cause, the sound becomes easier to remember. Let's start with normal. Because if you don't know normal, you'll never recognize abnormal. The most important normal breath sound is vesicular. Pronunciation, vesicular. Vesicular sounds are heard over most of the lungs. They're soft, they're low-pitched, and they're what healthy lungs are supposed to sound like. If you remember one normal breath sound, remember vesicular. Now let's talk about crackles. Every nursing professor describes crackles the same way, Rice Krispies. At this point, I think Rice Krispies should sponsor nursing school. Crackles sound like tiny popping noises, or Velcro being pulled apart. And here's what I think when I hear crackles. Fluid. That's it. Fluid. Pulmonary edema. Heart failure. Pneumonia. Fluid. A nurse hears crackles in both lower lung fields. Pause here and think about what findings should come to mind first. Ready? Crackles make me think fluid first. Always. Then I figure out why the fluid is there. Let's lock this in. Resonance equals normal air. Dullness equals fluid. Hyperresonance equals too much air. Vesicular sounds are normal breath sounds. Crackles make us think fluid. And understanding the cause of the sound is much more powerful than simply memorizing the sound, because that's how real nurses think. In the next section, we're tackling wheezes, raunchy rhonchi, pleural friction rubs, and some of the most commonly tested respiratory findings in nursing school. Okay, friends, welcome back. We just talked about normal breath sounds. Now we're moving into the sounds that make nursing students question their sanity. Wheezes, rhonchi, pleural friction rubs. And honestly, once you understand what's causing them, they're not nearly as scary as they seem. I don't memorize these sounds. I ask myself one question: what is causing the sound? Because once you know the cause, the answer usually becomes obvious. Let's start with wheezes. Wheezes are high-pitched, musical, almost like air squeezing through a tiny straw. And honestly, that's exactly what's happening. The airway has narrowed. Air still wants through, but now it has to squeeze through a smaller opening. Asthma, bronchospasm, COPD. These are all situations where wheezes can occur. So when I hear wheezes, I immediately think narrowed airway, every single time. Here's how I remember it. Imagine trying to blow air through a coffee stirrer. The opening is tiny. Air can still get through, but it sounds different. That's a wheeze. Okay, friends, let's see if this is making sense. A nurse auscultates high-pitched musical sounds during expiration. Pause here and think about what findings should come to mind first. I'll give you a few seconds. Ready? Narrowed airways. Those sounds are wheezes. And wheezes make me think airway narrowing every time. Now let's talk about rhonchi. Pronunciation, rhonchi. This is one of those words that sounds way more complicated than it actually is. Rhonchi are coarse, low-pitched. They sound wet, congested, like mucus is hanging out where it shouldn't be. Because honestly, that's usually what's happening. When I hear rhonchi, I think secretions, mucus, junk in the airway. And here's a test tip. NCLEX absolutely loves this. Rhonchi often improve after coughing. Why? Because coughing helps move secretions. If the mucus moves, the sound changes. And that clue alone can help you identify rhonchi on an exam. A nurse hears coarse, low-pitched breath sounds. The sounds improve after the patient coughs. Pause here and think about what breath sound this describes. Ready? Rhonchi. Because rhonchi are often caused by secretions that can move with coughing. Now let's talk about the breath sound that nobody forgets once they hear about it. Pleural friction rub. This occurs when inflamed pleural surfaces rub together. And honestly, the name tells you exactly what's happening. friction, rub. Two irritated surfaces moving against each other. This is not a normal finding. It often indicates inflammation involving the pleura. And unlike rhonchi, coughing usually does not make it go away because the problem isn't secretions. The problem is inflammation. Listen, this is important. Most students try to memorize crackles, wheezes, rhonchi, pleural friction rub as 4 completely separate facts. I don't. I think about causes. Crackles, fluid, wheezes, narrowed airways, rhonchi, secretions, pleural friction rub, inflammation. And suddenly respiratory assessment becomes a lot easier because you're understanding, not memorizing. Let's lock this in. Crackles equal fluid, wheezes equal narrowed airways, rhonchi equals secretions, pleural friction rub equals inflammation. And remember, if you understand what's causing the sound, you'll remember the sound. That's the cheat code. In the next section, we're tackling voice sounds. Bronchophony, egophony, whispered pector illoqui. And yes, that's the section where your patient suddenly starts sounding like a goat. Okay, friends, we've made it to the section that causes more confusion than almost anything else in respiratory assessment. Voice sounds, bronchophony, egophony, whispered pector illoqui. And honestly, the first time I learned these, I thought nursing school was messing with me because somehow hearing your patient more clearly is actually bad. That feels backwards. But by the end of this section, it's gonna make sense. Before we talk about any of the voice sound tests, I need you to remember one thing. Fluid carries sound better than air. That's it. That's the cheat code. Write it down. Put it on a sticky note. Text it to your study group. Fluid carries sound better than air. Because once you understand that, all 3 voice sound tests become easy. Normally, healthy lungs are full of air. Air muffles sound. So when a patient talks, you should not hear them clearly through the chest wall. Muffled is normal. Let me say that again. Muffled is normal. Because NCLEX loves to test that. Bronchophony, pronunciation, bronchophony. At some point, I thought they were making this word up, but it's actually simple. The patient says 99. Your job is to listen. That's it. Normal lungs, the sound is muffled. Abnormal lungs, the sound becomes loud, clear, distinct, almost like the patient is talking directly into your stethoscope. And if that happens, your brain should immediately think consolidation, because something is helping sound travel more efficiently. Okay, friends, let's see if this is making sense. A nurse asks a patient to repeat 99 while auscultating the lungs. The words sound unusually loud and clear. Pause here and think about what that finding suggests. I'll give you a few seconds. Ready? Consolidation. Because fluid carries sound better than air. Egophony. Pronunciation. Egophony. Okay, friends, this is my favorite one because it's absolutely ridiculous. The patient says, E, simple enough. But when you listen, you hear A, and suddenly your patient sounds like a goat. Congratulations. Your patient is not turning into livestock. That's egophony. And once you learn it, you'll never forget it. Normal lungs, no goat sounds. Consolidated lungs, now E sounds like A. And that's why NCLEX loves this finding, because it's weird. And weird things are memorable. A patient says E during a respiratory assessment. The nurse hears A. Pause here and think about the finding. I'll give you a few seconds. Ready? Egophony, a classic sign of lung consolidation. Whispered pector illoqui. Pronunciation, pector illoqui. And yes, that is a ridiculous word. The patient whispers, usually numbers, usually 1, 2, 3. And your job is to listen. Normal lungs, the whisper is faint, hard to hear, muffled. Abnormal lungs, you hear the whisper clearly. Again, the same concept. Fluid carries sound better than air. Same cause. Different test. Let's see if you've got it. Bronchophony. Patient says 99. You hear it clearly. Egophony. Patient says E. You hear A. Whispered pector illoqui. Patient whispers. You hear it clearly. What do all three have in common? Consolidation, fluid, increased sound transmission, same concept. 3 different tests. Okay, friends, let's do a rapid fire review of the entire respiratory assessment. Crackles, fluid. Wheezes, narrowed airways. Rhonchi, secretions. Pleural friction rub, inflammation. Tripod position, respiratory distress. Barrel chest, COPD. Resonance, normal air. Dullness, fluid. Hyperresonance, too much air. Fremitus, vibration. Increased fremitus, consolidation. Patient says E, and you hear a egophony. Patient says 99, and you hear it clearly, bronchophony. Patient whispers, and you hear it clearly, whispered pector illoqui. And what's the biggest cheat code from this entire lecture? Fluid carries sound and vibration better than air. Okay, friends, if respiratory assessment feels overwhelming, that's normal. The first time I learned this stuff, it felt like 50 unrelated facts. But once I realized that most respiratory findings come back to a few simple concepts, everything started making sense. Can the patient move air? Can the patient exchange gases? How hard are they working to do it? And remember the biggest cheat code from this entire series. Fluid carries sound and vibration better than air. If you remember that, you'll already be ahead of where I was when I first learned this material. Good luck on your exam. You've got this. And I'll see you in the next cheat codes for nursing students video.